Thank you for inviting me to give this presentation. My name is Nigel Davies and I am a consultant ophthalmologist at St Thomas's Hospital in London. On this photograph with the beautiful rainbow, you can see the London Eye on the left, and the other end of the rainbow lands on the north wing at St Thomas's Hospital. On the right of this slide, the image shows Westminster Bridge, a photograph taken about 100 years ago. I walk across this bridge every day, and in the distance, on the right of the photograph, you can see St Thomas's Hospital. Some of the structures on the bridge are the same today as they were then. In this presentation, I will talk briefly about diabetes mellitus in China, and most of the presentation will be about the effect of diabetes on the eye. We will start at the front and we will move towards the back. This very interesting paper was published in October of this year in the Journal of Diabetes. It indicates that in 2021 the number of people in China with diabetes was over 117 million. The annual incidence of diabetes was slightly over 4 million people, and the disability adjusted life years reached 11,700,000. In 2021, there were 178,475 deaths in China from the effects of diabetes. This article, published in 2019 in Diabetes Therapeutics, indicates the economic burden of diabetes in the Hainan province. The medical expenses managing diabetes added up to 242 billion renminbi. There is a quote from the paper which clearly states that diabetes mellitus places tremendous financial pressure on Chinese society and on the individual's family. The risk of a diabetic patient's family falling into poverty is high. And there is no doubt that diabetes is a huge worldwide problem. So what can ophthalmologists do? Our role is to preserve vision and to prevent vision loss and to try to reduce the disability caused by this disease. We can do this by having a good understanding of the problem. So if we start at the front and work our way to the back, the cornea, the horn-like structure of the eye, has its three layers: epithelium, stroma and endothelium. Diabetes affects all three layers. The corneal epithelium will have a loss of corneal nerves, and this can lead to recurrent erosions and a loose epithelium. The image on the left shows a neurotrophic ulcer in a diabetic patient, and the images on the right show the damage to the corneal nerve plexus that diabetes causes. So what about the corneal stroma? Is it thicker than normal, thinner than normal, or is it the same? This nice article in the Journal of Glaucoma, published in 2010, indicates that the cornea in diabetes is slightly thicker than in normals. This is very interesting. The reason for the slightly thicker cornea is because of the loss of endothelial cells in diabetes. This study, published in 2013, indicates that in fairly young patients with type 1 diabetes, the number of corneal endothelial cells is significantly reduced. This could clearly account for a slightly increased corneal thickness. What about the iris? This is a beautiful structure, and on the right we have the Greek goddess Iris, the goddess of the rainbow. Diabetic iridopathy can relate to nerve damage that occurs because of the diabetes, and also there is some damage to the iris pigment. The net effect of that is that the iris dilates poorly. You can see in the photograph here taken during cataract surgery that the pupil is only mid-dilated. The most important sign on the iris for diabetes is to examine it for rubeosis. On the left there is a picture of very obvious rubeosis. It would be easy to spot that, but do remember that rubeosis can be very subtle. Here is a dark brown iris, and at high magnification you can see a small amount of rubeosis around the pupil. And with gonioscopy, one can definitely see here rubeosis in the angle, and this will lead to rubeotic glaucoma. Diabetes is also an independent risk factor for primary open-angle glaucoma. This very good study published in 2014 shows that the odds ratio for developing primary open-angle glaucoma in a patient with diabetes is around 1.5. The word for lens has its origin in the lentil, and on the right you can see a lentil salad marked as lenses salad, and these beautiful microphotographs on the left show you the exquisite structure of the crystalline lens. Acute diabetic cataract can occur very rapidly. This is because of osmotic swelling in hyperglycemia, causing a significant disruption of the lens fibers. If you look at this patient, you can clearly see advanced cataract in the right eye, and the lens in the left eye is already going milky. The key point is that the skin of this patient indicates they are young. This is an acute diabetic cataract, which can happen, as I said, very rapidly. As advanced glycosylated end products accumulate, the lens will become hard and brunescent, and indeed about 20% of cataract surgery is performed on patients with diabetes. And we are very pleased to say that at St Thomas's Hospital, this gentleman, Sir Harold Ridley, performed the first cataract operation with intraocular lens implant nearly 75 years ago on the 8th of February 1950. We move further back now to consider the vitreous for a few moments. This is the glass-like body of the eye, as you know, and there are some lovely photographs here of the vitreous fiber structures. The diabetic vitreous is very abnormal. One can have increased vitreoretinal traction, increased epiretinal membrane formation, and the vitreous acts as a reservoir for angiogenic factors and as a scaffold for new blood vessel growth. There is a whole subspecialty of vitreoretinal surgery, and a large proportion of that will be related to the vitreous abnormalities that occur in diabetes, and unfortunately we do not have time to go into this in great detail in this presentation. And we reach the retina, the little network, named because it is the small net that surrounds the vitreous body when an eye is dissected. The retina is the site that is affected mostly in patients with diabetes, and in the UK in 2004 a national screening programme for diabetic retinopathy started, and this has reduced the rate of blindness from diabetes in the UK. Diabetes is now the second most common cause of blind registration. The first commonest cause is now that of inherited retinal disease. We use a grading system to classify the level of retinopathy when patients attend the screening program. The R1 grade has hemorrhage, microaneurysms, venous loops, exudate, and any number of cotton wool spots. In R2, which is moderate retinopathy, one can have venous beading, reduplication, multiple blot hemorrhages, and intraretinal microvascular abnormalities. R2 is severe if the retina follows the 4-2-1 rule, where there are 4 quadrants of hemorrhages, or 2 quadrants of venous beading, or one quadrant with intraretinal microvascular abnormalities. Any eye with 2 or more of these is deemed to have very severe non-proliferative diabetic retinopathy. As the problem advances and neovascularization appears, R3 is the term we use to indicate proliferative retinopathy. R3A for active is new vessels on the disc, new vessels elsewhere, pre-retinal hemorrhage, fibrosis or traction retinal detachment, and R3S is the treated stage where everything is stable. This can be related with pre-retinal fibrosis and laser scars and stable R2 or R1 features and laser scars. It is always good to ask why. Why do these changes occur? This is because of non-perfusion, the relentless damage to the capillaries in diabetes, and the loss of blood supply produces these visible changes in the retina. All of the visible changes we see in the retina from diabetes are the result of non-perfusion. We cannot see the loss of capillaries, they are too small just on the colour fundus photograph or on biomicroscopy, but we can see the consequence of the non-perfusion. The additional grading notation that we use is P0 for no photocoagulation scars, P1 for photocoagulation scars, and U to indicate ungradable. I will talk about maculopathy in a few slides' time. Here we have an example of R3 retinopathy on the right with a pre-retinal hemorrhage and multiple other areas of abnormality with exudate and hemorrhage. On the left there is significant exudate, so this patient has maculopathy, and there are other more peripheral changes, but one cannot see any new vessels. And on this slide there are some photocoagulation scars reaching up to the arcade vessels, so this indicates on the right that the patient has stable treated proliferative diabetic retinopathy, the R3S grade, but on the left there is a small pre-retinal hemorrhage and there are photocoagulation scars, but this would be graded as R3A. Here is a wide field laser scanning ophthalmoscope image of a patient with multiple hemorrhages in all 4 quadrants, and there is also some venous beading, so this would be graded as very severe non-proliferative diabetic retinopathy. I will show you the photograph of the same patient's other eye, and this at the first look appears very similar. However, you do have to be very careful looking at these photographs. If I zoom in a little bit, on this next slide, you can clearly see down at the bottom right hand corner there is a fairly large area of new vessels. Be very careful when looking at these images. We perform a fluorescein angiogram, and it is easy to note that this angiogram shows a significant number of new vessels that are leaking the dye both infratemporally, supratemporally, temporally and nasally. Let's go back to the patient's other eye. We said this patient had very severe non-proliferative diabetic retinopathy, and indeed that is what we can see when we look at this colour photograph, but it is very interesting to look at the angiographic slide which is coming next. Here one can see clearly the extent of the non-perfusion in this patient's eye, and you can also see that this patient has early proliferative diabetic retinopathy on this side as well. It is also extremely interesting to note that where the retina is not perfused, this is where the microaneurysms occur. This is a very clear indication that the visible signs of diabetic retinopathy are a consequence of non-perfusion. It is very important to look extremely carefully at these photographs. This photograph actually looks like the patient does not have too much of a problem. If we zoom in a little, there is clearly an area of vascular abnormality on the left. And when we perform fluorescein angiography, we can see this patient has early neovascularization. My colleague Samantha Mann will talk more about the treatment for proliferative diabetic retinopathy, but here one can see a patient who has multiple laser scars from significant panretinal photocoagulation, but this has controlled the proliferative disease. One can see areas of fibrosis which are on the superior vascular arcades, and this is a good result from panretinal photocoagulation. In this last section for the presentation, I talk about diabetic maculopathy. And diabetic maculopathy that is significant is defined as exudate within one disc diameter of the center of the fovea, or a group of exudates within the macula, or any area of thickening within one disc diameter of the center, and or microaneurysms or hemorrhages within one disc diameter of the center of the macula if the vision is worse than 612. We are aided enormously by optical coherence tomography in the assessment of diabetic maculopathy. Here is a colour fundus photograph of a patient with a large area of diabetic maculopathy with a circinate exudate, and the OCT scan through the centre of this patient's macula clearly shows very significant diabetic macular edema. This patient underwent focal laser treatment and also anti-VEGF injection, and although everything was treated quite aggressively, the edema was very persistent. This image was taken 4 years after the previous one, but after further laser, good control of the diabetes, and several more anti-VEGF injections, the area in this patient's macula looks much better. This is also demonstrated on the OCT scan with a significant reduction in the amount of exudate and a significant reduction in the amount of intraretinal and subretinal fluid. Here is another patient who presented with quite badly affected vision from very significant diabetic maculopathy. You can see from the scanning laser ophthalmoscope image on the left there is a significant amount of exudate and hemorrhage in this patient's macula, and the exudate is causing a very large amount of disruption of the OCT scan through the center of the fovea. This patient underwent multiple treatments with anti-VEGF agents, and my colleague Mrs. Mann will talk about this in the next presentation. But slowly and steadily things began to improve. The hemorrhages resolved, the exudates began to resolve, and the patient's vision began to improve. In 2020, there was still some significant edema, but the hemorrhages have now improved quite considerably. And this patient had multiple treatments, and this image taken in 2022 shows that the majority of the exudate has now resolved. The structure of the fovea has been restored as well as we can. The patient's vision is slightly reduced, but is much improved in comparison with presentation, and the patient continues to need ongoing treatment. This indicates how dedicated one needs to be to keep going with treatment for these patients to maintain a good level of vision. This is a patient who had 2 areas of macular edema, and I treated them both with focal laser, and 3 months later you can see that one area has completely resolved and the other has only partly resolved. This is my analysis that focal laser treatment actually works about half of the time. I treated this area of edema a second time, and it did indeed resolve. With proliferative diabetic retinopathy, one cannot rely on the OCT to make a diagnosis, but sometimes you will see new vessels on the OCT scan. Here is a patient. The scanning laser ophthalmoscope image on the left shows some hemorrhage, and it is flat-topped inferiorly, indicating that it is in the vitreous. The scan, however, across the retina shows that on the far right there is a small tuft of vessels which is lifting itself up into the vitreous, and this is the indication of the new vessels in this area of the retina on the OCT. It is very important on the OCT scan to look for this change, as it will be very helpful in diagnosing proliferative diabetic retinopathy. The signs of proliferation on an OCT scan can be very subtle. This is a patient who has previously had macular edema. On the scanning laser ophthalmoscope image, one can see the laser scars from the treatment that I performed, and the OCT scan shows that the macular edema has resolved. If you look on the right part of the image, you will see the optic nerve appearance as the nerve fibers disappear out through the back of the eye, and this all looks fine. Interesting to look at the next picture. The macular edema has not returned, but there is a new appearance just by the optic disc on the right of this image. These are the new vessels that have started to perform, and this indicates that the patient needs panretinal photocoagulation. Always be very careful to look at the OCT for signs like this. They are very subtle, but they are very important. In summary then, diabetes mellitus affects the whole of the eye. Because of the damage to the nerves, to basement membranes, to proteins, to blood vessels, we have problems with the cornea, the iris, the lens, the vitreous and the retina. Diabetic retinopathy is the result of non-perfusion, and all of our treatments are aimed at reducing the effects of this non-perfusion. I thank you very much for listening to this presentation. My colleague Samantha Mann will continue with much more detail about the management and the treatment that we can give our patients with diabetic retinopathy. Thank you very much for your attention.